Welcome to the webinar, Mastering the Fundamentals of Clear Aligner Therapy. The lecture will be presented by Dr. Yaman Tahine, and we will begin shortly. And now from Eon Dental, it is my pleasure to introduce Dr. Farah Majdalawi and also Dr. Yaman Tahine. Dr. Tahine graduated from the University of Georgia with a diploma in primary care dentistry and specializes in clear aligner therapy. As a clinical success specialist and educational consult, he has overseen hundreds of cases, published articles, and collaborated with global experts to advance knowledge in dental technology and clear aligners. And with that, it is my pleasure to say, take it away, doctors.
Thank you very much, Jessica, for the introduction. Good afternoon, everyone, and welcome. My name is Farah Majdalawi. I'm a clear aligner education specialist. It's a pleasure to have you all here today to go over the foundations of clear aligner therapy. But before we begin, I would just like to make a very brief disclosure. Both Yaman and I are employees at Eon Dental, and this webinar is being financially compensated by NDX to Eon Dental. Over the next hour, we'll be going over the foundations of clear aligner biomechanics. We'll be talking about exactly how clear aligners work, how they bring about specific tooth movements, as well as the basics of case selection and treatment planning. Our goal is to equip you with the knowledge needed to start integrating clear aligners into your dental practice with confidence. With all that being said, I'll hand it over to my colleague, Dr. Yaman. Yaman, the floor is yours now.
Thank you, Jessica, and thank you, Farah, for the introduction. Hello, everyone. This is Dr. Yaman, and I'd like to welcome all of you to the webinar today. Now, I'm very excited for this lecture, and I'd like to go straight into it. So, the title of our lecture today is Mastering the Fundamentals of Clear Aligners Therapy. And in my opinion, in order to master the fundamentals of any topic, you'll need to be able to answer the most basic questions, and you start with the most basic questions. Similar to this bystander here in this illustration that's looking at a very big street ad and boldly asking, what are clear aligners? Now, to kick off our lecture today, I would like to tackle this very question. But before we do that, I'd like to take a look at some recent articles and number. For example, we have this recent article here published in the British Dental Journal, and it discusses the rise in demand for tooth straightening among adults. And it says that over 70% of orthodontists report an increase in adults seeking orthodontic treatment within the past 3 years. And this article also discusses the Zoom boom effect with after the pandemic, with the shift to remote work and the video calls. So a lot of people are becoming more aware of their appearance and their dental issues. More interesting part of this article is that 82 of orthodontists surveyed state that more patients are seeking alternative treatment options as a result of the pandemic and moving to digital communications. And this is where innovations like clear aligners and digital scannings have made orthodontic treatment more convenient and less intrusive. So more numbers coming through. If we look over here at this report that was published in 2018 by Statista Research Institute, we'll find that in 2018, the market value for clear aligners was around 1.95 billion US dollars. And the forecast is speculating that by the year 2027, the market volume for clear aligners is going to be around $7 billion. It's going to be more than 7 billion US dollars. But I'd like to bring your attention to the year 2023, where the market value was predicted to be around 3.85 billion US dollars. But if we move to a more recent report, this report was back in 2023, and it was reporting that the market value was at $4.6 billion. So this only means that aligners are exceeding expectations. And with 45% of the global market accounted by the North America region in 2023, it only makes sense to assume that more and more of your patients, the patients that are frequenting your clinic, are going to be asking this simple questions: what are clear aligners? And in order to answer with the most simple terms, clear aligners are a device, an orthodontic device that help doctors move teeth and align them in the correct way. So it does that by using a series of plastic trays These are tailor-made plastic trays that are removable and transparent, and they are made with a slight mismatch according to your teeth. This slight mismatch will generate push forces that will move teeth to the desired position. It's important to note that these removable appliances should be worn at least 20 hours a day, 22 hours a day, and each tray is going to be worn for a full week. So what I like usually to tell patients is that these devices should be worn basically the whole time, except when you are going to eat and drink or like clean your teeth. Otherwise, you'll need to comply and use the device almost all of the time. So by now, we have a basic understanding of what clear aligners are, but this might work for someone without a dental background. But since most of us here are dental professionals, I suppose everyone here is a dental professional, this definition doesn't quite cut it. We need to go zoom in a little bit closer, take a closer look and see what happens actually behind the scenes, whether it was the workflow in the clinic or the manufacturing process by the clear aligner provider. So this is the whole case life cycle. I don't want to overwhelm you with everything right now. I just want us to focus on these 3 initial stages, starting from initial consultation, records collection, and case submission. Before we do our initial examination, and even before considering to offer clear aligner solution to any patient, we need to check these boxes, these patient selection criteria. We need to make sure that we're selecting the right patients, the right candidates for clear aligner treatments. And with everything we said about the device being removable and the need to wear the device for 22 hours a day for it to work, obviously we need, for a good candidate for clear aligners is going to be a compliant patient. It needs to be a compliant patient. 50% of the success depends on the patient wearing the device. So it's really important before starting the treatment with clear aligners. Usually I have a long talk with patients. I explain thoroughly that this treatment depends on their compliance for success, and that if they don't comply, they're just going to be wasting my time and theirs. So there is no point. So it's really important always to check for compliant patients. And of course, as any other orthodontic treatment, you need to reach good oral hygiene and maintain good oral hygiene habits in order to start your orthodontic treatment. Otherwise, you're going to face issues such as caries and staining, these side effects of any orthodontic device or tool that is going to be used before reaching good oral hygiene and good oral hygiene habits. Now, clear aligners therapy is going to be good for patients who are inclined towards aesthetic treatment options, obviously with it being a discrete alternative to fixed metal braces. So, and with the increase, with the trend going towards aesthetic and dentistry, this is going to be a good selling point for clear aligners to a lot of your patients. Also for patients who have limited access to dental visits, so patients who are working a lot, who are always on the go, who need to travel a lot, clear aligners require a minimal number or a less number of visits compared to fixed braces. So this is a treatment modality where you can you're going to manufacture the aligners from the beginning of the treatment. You're going to give a number of aligner trays to the patient, and they're going to change them every week. A lot of the times, you don't need a lot of follow-up appointments unless you're going to change an elastic, or you're going to just follow up on the patient and check that everything is going all right. So patients with limited access to dental visits, this is going to be a perfect treatment modality. Finally, with the hype that's been going around clear aligners in the recent years, there is a lot of talk about clear aligners being faster, or they have shorter treatment duration in comparison to the fixed orthodontic appliances. And while this may be true in a lot of cases, and a lot of studies show that a lot of malocclusions can be treated with aligners in shorter treatment duration compared to fixed braces, it's always important to know that these aligners are not a magic tool. If it is a severe case, for example, if you're going to treat a severe deep bite and you're planning to fully correct the severe deep bite with clear aligners, it is not going to be fully fixed, whether it was clear aligners or fixed braces. It's not going to be fixed with 4 to 6 months. So for the treatment duration, whether the expectation of the patient was high, you need to set the right expectations. You need to know what certain type of malocclusions are going to be smooth treatment that is predictable with minimal refinements and follow-ups, and what treatments are going to need some intervention and refinements after the initial set of aligners. Okay, moving on to the initial examination, it's going to be similar to the normal examination that we do before any orthodontic treatment. We're going to need medical and dental history. We're going to do the extraoral examination, regular facial analysis, and soft tissue analysis. For the intraoral examination, I don't want to bore you with details. It's the regular dental examination that we do, or the regular soft tissue and periodontium examination. This is the important checklist that I want us to reach. So in digital orthodontic treatment, planning is a big part of the result. 50% of your work or your success in the treatment plan is going to depend on the right planning, and the right planning requires the collection of the right information. So by the end of your dental examination, I want you to have this checklist in mind, to keep in mind the tooth size and shape anomalies, to document the canine and molar relationships, to check for any crowding or spacing and the severity of this crowding, whether it was mild or moderate to severe. You'd need to measure the overbite and the overjut. You need to keep an eye out for cross bites and any vertical issues such as open bites and deep bites. You need to keep an eye for functional shifts and midlines. And this might sound a little obvious since we're doing an orthodontic treatment. These details should be collected, but with my experience, a lot of the time, you've seen that you can miss a slight midline shift that's going to change how you treat your plan, how you plan your movements. So it's really important to have all of these checked while you're doing the examination, and to be able later to document these information during case submission, because once we get to case submission, you need to know that the dental technician that is treating your case, that is moving the teeth on the software, doesn't actually see the patient clinically. So we have to keep that in mind. We have to give the technician the biggest amount of information we have around the malocclusion, around the orthodontic malalignments, and we'll need to document that in the right way during case submission. So moving on to records collection, the default records that you're going to need for any aligner case. For extraoral photos, you're going to need a frontal photo, and also a frontal photo with the patient smiling, a side profile. And for intraoral photos, you're going to need the frontal view, left and right buccal views, and upper and lower occlusal views. So these are the default. You need to make sure you take them for every patient. They provide a huge amount of information that is needed to plan the treatment in the right way. An integral part of records collection is also the impression and the bite registration. Now, whether you're taking an intraoral scan or a silicone impression, you always have to ensure that your impression is flawless with clear gingival margins to avoid, we need to avoid any defects. In intraoral scan, these can be the duplication, the double images, and whether with traditional impressions, we're going to have defects such as bubbles or double impressions or missing anatomy. We need to make sure that we avoid any of these defects. And if we have any of these defects, we'll need to repeat the scan, because if we proceed with any of those defects, it's going to cause the aligner to have a fitting issue in the initial appointment. Or if you're unlucky, it's going to fit initially, but it's going to cause a cracking issue later on when you are moving the teeth. So again, it's really important that impressions with defects should be retaken to ensure a good quality treatment setup and good aligners fit. And also an important note that when you're doing a single arch treatment, if you're treating a single arch, it's always important to include both arches in the impression or the record, because you're going to be predicting the teeth movement on the simulation, and you're going to keep an eye out for possible interferences, since we're not moving the lower arch with the upper. For example, if we're treating an only lower arch, we have to avoid interferences. And this is why we always need to take an impression of both arches, even if we're treating a single arch case. Lastly, in the records collection, we're going to need the following X-rays. So it's the panoramic radiograph and the lateral cephalogram. It's important for the ortho analysis of the case and planning the case correctly, making sure that we have all the information we need about the patient's profile and what type of movements we can do without affecting the external appearance, or with improving the external appearance with the patient, to avoid any movements that would worsen the extraoral appearance of the patient. So by now we've covered the initial consultation, the records collection, and we'll reach the case submission. So you will go to the portal or the platform that your clear aligner provider uses for case submission. An important part of case submission is always to cover your chief complaint. What is the chief complaint that you're going to treat? What malocclusions are you accepting and what malocclusions are you treating? So in some cases, we're not going to treat all of the malocclusions. The patient might be okay with a half unit class 2 relationship, but they just want anterior alignment. And it's really important to mention that while you're doing your case submission, because this is going to differ with the treatment duration a lot. So when the technician receives a case, he's going to assume that you'd want to treat all the malocclusions unless you specify what you want to treat. So unless you say you're going to accept the class 2, the technician is going to attempt to correct the class 2 relationship and the result is going to be a longer treatment setup than you're expecting and that the patient is expecting. So it's always important to mention what are your treatment goals, what are you accepting, and when you are getting more advanced with the aligner treatment, you can start mentioning how would you like to achieve this treatment goal. So for example, if you have a crowding case, you have the options to provide space, whether by expansion of the arches, whether proclination of the anterior teeth, or using interproximal reduction. So if your patient is not okay with interproximal reduction, you've offered this choice, you've explained the safety, but the patient still doesn't want any interproximal reduction. You have to mention this during case submission to direct the technician to design your treatment setup the way you want. Now, once we're done with initial consultation, records collection, case submission, we're going to reach the treatment setup generation. And this is the part that happens outside of your clinic. This is the part that happens by your clear aligner provider. And while the exact number of days might vary from one clear aligner provider to another, the average is around 3 to 4 days. And once the treatment setup is out, you will be reviewing your treatment setup and approving it if everything is okay. Now, for treatment setup approval and treatment setup reviewing in general, you're going to need to have more knowledge about the biomechanics and the movements in clear aligners. So these parts we are going to cover as we go in the lecture. But for now, I'd like to take you a little bit for behind the scenes. What happens in your clear aligner provider? How is the treatment setup being generated? You need to have a full idea of the workflow in order to design your treatments the right way. So once the clear aligner provider receives the digital scans or impressions, they are exported into a CAD/CAM software for further processing. And the treatment plan is set up, as I said, by an experienced dental technician. The treatment setup is going to be presented to you through a 3D simulation or a video of tooth movement. Now, in this 3D simulation, the teeth are incrementally movement, adjusted in the virtual model, with each stage or each increment representing a tray. So every click that you do on the simulation, every stage is representing a clear aligner tray that the patient typically wears for 1 week, and it's going to move the teeth in this amount or this increment. Now, what you see in the video here is a typical simulation for movement for the lower arch. Here we're attempting to do lower anterior intrusion. So this is the view that you're going to see. It's going to vary from software to software, but in essence, this is what I mean when I say that every number that is changing in the lower bar over here is going to be an aligner tray that the patient wears for 1 full week. An important note and an important tip to always ask or make sure that you know whether your clear aligner provider incorporates clinical inspection of treatment setups by dentists and clinical specialists and orthodontists. They do this to ensure optimal treatment outcomes because no matter how experienced the dental technician or how skilled they are, they're still looking at this from a perspective that is not a clinical perspective. They're not fully aware of the predictable amounts of movement, of what movements are realistic and what movements are not realistic to achieve, what movements might cause issues that harm the patient. For example, if we do an excessive amount of proclination on a certain tooth, we might cause some damage by recession and clinical attachment loss. So it's really important to have these clinical inspection because these doctors are used to using this software, especially if you're starting with a new clear aligner provider. It's really important to have these dental clinical inspection because these doctors know the ins and outs. They know what the amount of movement that you see on the simulation, what does it translate to clinically? So you're going to depend on these doctors because they are used to seeing multiple cases on the softwares, and it's going to have a big effect on the quality of the treatment setups you get and the quality of the results you get while you're going through the treatment. Now, why is it important to have this clinical eye or clinical perspective? There is a sentence or an advice that you're going to hear in every aligner lecture or course, is that the 3D simulation, the video that we see over here, it represents the planned force system rather than an actual clinical movement on teeth. So again, as I said, this is a sentence you're going to hear a lot. And while it is true, I don't think it fully paints the picture. So if you go on with me, I think the right way to think about the 3D simulation is that it is a spectrum. So depending on the type of malocclusion and the type of movements needed to correct this malocclusion, whether these movements are predictable using clear aligners or are they challenging movements using clear aligners, you can think of it as two parts of this spectrum. So for cases, for example, spacing teeth, I'm going to explain later in the lecture why spacing cases are more favorable with clear aligners. But in spacing cases, I can trust the 3D simulation that it will represent the clinical outcome. So it's going to be predictable. While a more advanced or a more challenging malocclusion that requires more challenging movements, I need to start thinking of the 3D simulation as a force system, and I have to deal with it accordingly. And I'll give you an example to explain why. Just keep in mind that open bites, for example, are on the more predictable part of the spectrum, and deep bites are on the more challenging or less predictable part of the spectrum. So if you look at this clinical case, on the left side, we have the initial position and the final position of the treatment setup that I approved for this case. And on the right side, we have the initial clinical photos and the final result. So if you compare the final results, both at the simulation and the clinical photos, you're going to notice that they're very similar. So what I planned, what I saw in the 3D simulation actually took place fully, and all the movements happened predictably, and I ended up with this beautiful result. But if we deal with a more severe case, here we have a deep bite as opposed to the open bite that we saw, because as I said, the open bite, I know that it is more predictable. I know the movements required to correct an open bite are more predictable, so I can just depend on the 3D simulation. While if I'm treating a more challenging malocclusion for deep bites, I know the movements required to treat the deep bites are challenging. I know, for example, posterior extrusion is required to correct a deep bite, and it's very challenging with aligners. So as you can notice in the final setup, in the final position in the treatment setup, the bite is overcorrected. So I reached almost edge to edge or almost an open bite anteriorly in order to get this correction of the deep bite on the right side. You can see in the clinical photo in the final result. So it's not as simple when you're dealing with challenging cases. It's not as simple as overcorrecting and reaching an edge to edge and open bite. I'm just using this as an example to guide you with how you can view your treatment setup and how you think of them. So it's not always accurate prediction, and it's not always inaccurate. You have to understand every movement separately in order to really know whether the setup you're seeing is accurate or would you need overcorrection like this case. So by now we've finished the whole case life cycle. We've reached the manufacturing and shipping. This usually takes around 7 to 10 days. And I'll take you a little bit also behind the scenes for manufacturing. Once these are approved, once the treatment setup are approved, each stage that we mentioned, each aligner tray stage, is going to be translated to a digital STL file. And these STL files are fed into the 3D printing machines, which then print out solid 3D models for each stage of the treatment setup. Moving on to thermoforming, the next stage, once the 3D models has passed the approval, post-processing and the clear aligner material is thermoformed to the cast, and automatic cutouts and trimming of the clear aligner is done according to the required specifications. So by now we've reached the third stage of our presentation today, which is going to take the bulk of our presentation. I just wanted you to take a little bit of an introduction, the aligners in simplest terms, take a little bit of an idea on the background and what happens behind the scenes from workflow to manufacturing. But when we reach this stage, when we talk about case selection, we need to zoom in a little bit more, and we need to take a closer look into the biomechanics. Why do I say biomechanics? Because once you master the biomechanics, you're going to master the different movements with clear aligners, and you're going to be able to select your cases accordingly. So we have these two lists over here. On the left side, we have some ideal starting cases, and there is a list of malocclusions under that. And on the right side, we have more advanced cases. So this seems easy. I just take a look, I just memorize these lists, and I will know how to treat my patients, or which type of malocclusion is more predictable and which isn't. But unfortunately, like we all know that it's not that easy, because malocclusions don't come according to a catalog. Like these malocclusions might overlap. We might have variation with the same malocclusion having different severities. We have certain factors that determine severity that are outside of just the malocclusion. We have other dental factors. We have age factors. So it's not always easy to just memorize a list and know these are, for example, I'll just memorize that class 1 spacing or minor to moderate crowding is an ideal starting case, and I'll just disregard any deep bite case and I won't treat it. No, it's not that simple. The way to actually memorize this is to understand the biomechanics and the movement behind this. Once you understand the movements and you know which movements are predictable and which movements aren't, you're just gonna, whenever you get a new patient, you're just gonna take a look at the teeth. You're gonna start imagining what movements are needed in order to reach the final beautiful alignment or the final position that I want to reach. And according to these movements, I can determine whether this is a good or an ideal starting case or a more advanced case that I should keep for later on in my clear aligners journey. So in order to start with biomechanics, I want us to differentiate between, or like understand the main difference between the biomechanics in fixed appliances and the biomechanics in clear aligners. So we're used to look at the science of moving teeth through the lens of fixed appliances, because this is what we learned in dental schools and this is what we're used to. Fixed appliances exert pull forces on teeth in order to reach the final alignment, the final wanted alignment. While in clear aligners, we exert a push force. This is not something that we're not usually similar to. And this is why we need to keep an open mind. We need to imagine how the plastic is going to apply these push forces over the teeth in order to imagine which movements are going to be easy and predictable and achievable with the plastic of the clear aligner, and which movements are going to be a little bit more challenging. So before we move on to clear aligners, I just want us to refresh or like to point out these two important points about fixed appliances. So for fixed appliances, we have this assembly of brackets and wires, and all of the materials that are included into this are rigid and strong materials. They exert controlled and continuous forces over the teeth. And this allows them to apply certain movements that are very challenging, such as root and torque control. This is challenging movements in orthodontics in general, whether we're talking about clear aligners or fixed braces. Root control is always difficult because we cannot apply forces directly to the root. We can apply through the bracket or the clear aligner plastic, but control over the root is really difficult in general, whether it was fixed braces and clear aligners. But because of the factor we mentioned about fixed braces, the rigidity, the strong materials, they're able to exert a little bit of more of a control. So we have to keep this in mind while we're planning movement with clear aligners, that it is relatively less controlling over the root. So if we compare, like in clear aligners, we work with a push force, unlike the big fixed braces. We don't have the brackets. What we have is the plastic encapsulating the whole body surface of the tooth. The aligner material will flex beyond its flexural module, and it will want to get back to its original position, bringing the teeth back with it. This is an example of how an aligner can engage a tooth and apply a certain movement. As you can notice over here, the forces that the aligner applies to the teeth depend mainly on the natural undercuts of the teeth geometry. So by engaging snugly over the tooth with a slight mismatch, the aligner plastic is going to be able to exert a force on this undercut and push the tooth accordingly. So what we've been explaining so far is the shape molding effect, or what this is known in the lecture and can be defined as pre-established mismatches or activations between the aligner shape and the dental tooth geometry that generate three-dimensional force systems distributed all over the tooth surfaces. So what we can gather, or I want us to deduct from what we've mentioned so far about clear aligners and the difference between clear aligners and fixed braces, I want us to remember 2 points: that we have a material difference. The material that is used for clear aligner movement is relatively a little bit weaker. And we also have an absence of direct points of contact. So in fixed braces, we have these bonded brackets. These are direct points, the specific points for force application that allow the system to apply forces to teeth. While in aligners, we don't have a specific point. The aligner plastic is encapsulating the whole tooth as a whole, and it's trying to apply force accordingly. Now, what does this mean? It means that the more surface of the tooth that we cover, the more force that we're going to be able to apply. So this is why, for example, you're always going to hear that spacing cases are more predictable with clear aligners, because you have more of the tooth surface exposed. You have the proximal surfaces exposed in cases of spacing, which means that the aligner is going to be able to encapsulate these surfaces and apply extra additional force than it would be able to do if it wasn't a spacing case, or if the proximal spaces weren't exposed. Okay, so by now we have some theoretical understanding of the biomechanics of clear aligners. I just want us to take this practical example in order to have a deeper understanding of what we might face when we start actually moving teeth. So let's take the simplest movement possible. Let's assume that I want to move the central incisor, and I want bodily movement on it. I want it to maintain the same torque, the same angulation for the root and the crown, and I want to apply force with a clear aligner. Now, in this example, we're talking about clear aligners alone, without any auxiliaries. We're talking about the plastic alone trying to apply a force. So once the plastic is trying to apply a force in this direction, logically, the most amount of force is going to be near the incisal edge of the crown. So this is where most of the force is going, like the resultant vector of force from all the plastic that is engaging the tooth. It's going to be mostly near the incisal edge, and it's not going to be passing through the center of resistance. What does this create? This means that the root is going to be wanting to go the opposite way and creating a rotational movement around the center of resistance. So in this case, what actually happens, once we push the tooth in this we apply a force in this direction, we're going to get a movement in the opposite direction by the root, which ends up tipping the tooth in this way. So why am I explaining this? Because this is a residual. So I want us to keep this example in mind whenever we imagine a movement with clear aligners, whenever we're watching a 3D simulation of a treatment setup. I want us to keep this in mind, that I want to imagine you, I want you to imagine the plastic applying this force, and how is it going to translate clinically, because we're always going to get this side effect of tipping. So by now, let's establish that tipping is a side effect that happens with aligner, and we're going to learn how to avoid it, or how to work our way around it. There is multiple ways to work your way around this side effects and use it to your advantage. But this is how we learn with aligners, that the initial side effect is always tipping. So tipping is the simplest type of tooth movement that occurs when a single force is applied to a crown of a tooth. And what we always aim to reach is always control tipping, which allows a unidirectional crown movement while the root moves minimally in the opposite direction. In contrast, uncontrolled tipping, which we try to avoid unless it is favorable for our treatment goals, uncontrolled tipping tips the crown in the direction of the force while the root moves in the opposite direction. So moving on, we've learned the first practical advice, that aligners are always going to have a tipping side effect, and we're going to learn throughout the lecture how to work your way around the side effect. Another important point that you need to think of when you're planning a clear aligner treatment, that we understood so far the shape molding effect, or the displacement driven system that depends on the plastic and the plastic mismatch with the teeth. But sometimes to reach certain movement, let's say, for example, extrusion, or like we're trying to achieve bodily movement, we're going to need to apply pull forces. Push forces of the aligner are not going to be enough. And this is where auxiliaries come into play to exert these pull forces, or this is what we call the force-driven system. So these are mechanisms that utilize attachments and auxiliaries to deliver planned forces at specific site of the tooth surface. And some of them, as you can see over here, whether it was the temporary anchorage devices, whether it was the power arms or the elastics, are a little bit more advanced, and we might cover them in later lectures. But for now, I want us to concentrate on attachments, because almost in every case that you treat with aligners, you're going to need those attachments. This auxiliary It became an integral part of clear aligner treatment. And in every case, you're going to use these attachments. So it's really important to know how to use them. And because of the importance of these attachments and how they play a big role in clear aligner treatment, I would like for the following part to go over the different movements that are required for treating malocclusions and how attachments play a role in aiding these movements, or what type of attachment is the perfect fit for this type of movement. So I just want us to focus a little bit on the upcoming parts, because it's going to contain a lot of clinical advices on what attachments to use for different movements. So to define attachments, they are extensions that act as handles. They are composite extensions. They allow the aligner to exert push forces on the tooth and bring out specific movements in a more predictable manner. So let's go back to the engagement with aligners. We said, how do aligners engage teeth? By the plastic coverage of teeth and applying push forces. So a great part of the efficiency of the force approved by the aligner is going to depend on the size of these teeth. So for short clinical crowns, we're going to have less engagement. And for long clinical crowns, we are going to have more engagement of the aligner and more force applied. So this is where attachments come into play. For teeth with decreased surface area, where we're not going to have proper aligner engagement, we're always going to need to add attachment to increase the surface area of the tooth and to apply the forces in a certain direction or a certain way. So what we've been talking about so far is the passive, let's say, the passive roles of attachment, whether it was aligner retention or whether it was to increase the surface area of short clinical crowns. But for the rest of the lecture and the most important part, we're going to talk about the active aspect of attachments. So how attachments are used to aid in certain movements. These are the types of attachments. So of course, this might vary between one software and the other, one clear aligner provider and other. They are different between different systems. But when it boils down, these the types of attachments are going to cover most of the attachments that you need to know for clear aligners. So we have the horizontal, the oblique, the root control. I don't want to overwhelm you with them right now. The way I prefer to do this is go through the movements, and I'm going to mention for every type of movement what type of attachment is needed and on which teeth is it going to be placed. So let's start with the translational buccolingual movement. So this is expansion or constriction of the arches, the horizontal bodily movement of a posterior tooth in a buccal or palatal direction to increase or decrease the width of the arch. So we can do a good amount of expansion with clear aligners. We can be between 2 to 3 millimeters. It is achieved. And what we have to look out for, we can move the teeth for 2 to 3 millimeters, but we always have to keep the side effects in mind. So when planning expansion, the tipping that we already explained, because the forces are not passing through the center of resistance, is bound to happen. And when I'm planning bodily movement on this tooth on the left side, you're going to notice some flaring of the cusps is happening and the tooth is being tipped outside. This is why attachments are needed. So here we have horizontal rectangular beveled attachments, and the aligner is going to apply a vertical force on this attachment that is going to counteract the tipping side effect. And we're going to ensure that we get bodily buccolingual translation to do our expansion correctly. The same applies for translation or buccolingual translation for anterior teeth, whether we're talking about proclination or retraction of the anterior teeth, the horizontal movement in a labial or a lingual direction in case of retraction. Similarly, the predictable amount is 2 to 3 millimeters. We can get acceptable amount up to 3 millimeters of retraction. And regarding the attachment role, like while we might not require a certain type of attachment on the anterior teeth that are being proclined or retroclined, it's always important to provide anchorage by adding attachments on the posterior teeth. So posterior retention should be planned. As you can see in the simulation here, we have some horizontal beveled rectangular attachment on the lower molars. So even if we're doing the most simple types of movement, there is a minimum of 2 attachments per quadrant that need to be placed. I think the default is always going to be the first molar and the first premolar. Unless these teeth are missing or we can't place attachment on them, it's going to be on a different posterior tooth. But this is the minimum for any clear aligner case. So depending on any movement, you're going to increase attachments, but you're going to start with at least these 4 attachments in each arch, one on the first molar of each side and one of the on the first premolar. Okay, so we're going to move on to a more challenging type of movement, which is the distalization and mesialization. Distalization is the horizontal bodily movement of teeth away from the midline, and mesialization is the horizontal bodily movement of teeth towards the midline. Now you're going to see that distalization is a little bit more predictable, and we can do more distalization with aligners than mesialization. We can do 3 to 4 millimeters, and we can do 2 to 3 millimeters of mesialization. Now, I mentioned that this is a little bit more advanced or a challenging movement, but this is not related to the amount of movement. This is also related to the tipping. Again, when planning when planning to move teeth in a bodily direction, whether it was mesial or distal, crown tipping is bound to happen in the direction of movement. Thus, these attachments are essential to counteract these tipping. Here, in this case, you can notice whenever we're mesializing or distalizing, we're going to use vertical rectangular beveled attachments. And these are the most suitable attachments for mesialization and distalization movements to try to avoid tipping as much as possible. Because from my experience, most of you might know, like the tipping is more common to happen while we're doing mesial and distal translation in comparison to the buccolingual translation that we talked about in the previous slides. So let's assume that the tipping, the side effect that we've been talking about, already happened. So during the course of orthodontic treatment, the crown of certain tooth may be tipped in a mesial or distal direction, with the roots tipped in the opposite direction. The movement that is required to tipping these backs back into a parallel orientation is accomplished by angulation. So we have, because angulation, as you can imagine, depends also on applying forces to the roots and moving the roots, we have a small window of 10 to 15 degrees of predictable angulation. So I'm mentioning these numbers because once you get a setup and you're seeing a significant amount of a certain movement, you're seeing a significant amount of angulation on a certain tooth, I advise you always to check the movement table, the movement chart that is always attached to the 3D simulation of the setup, and see the amount of angulation that's actually happening. Is it within the predictable or acceptable window, or are you going beyond the predictable limits, which is going to always, it's going to be a matter of luck. Once you plan movements beyond the predictable limits, they might happen, they might not, and once they don't happen, you're going to have loss of tracking. So the aligners are going to stop fitting. You're going to move in with the numbers of aligners, but the teeth are not moving accordingly until the aligners don't fit at all, and you're going to need a new scan for mid-course adjustment. Of course, we're going to have a separate lecture on refinements and adjustments. This is just an introduction to give you an idea of basic movements with clear alignments and to be able to select the right cases along the way. So attachment's role in biomechanics, crown angulation, always requires the placement of attachment to provide 2 points of force application. So for most teeth, the suitable attachment is always going to be the vertical rectangular beveled attachment, unless we're talking about the upper central incisors, where these root control attachments, these, as you can see, these 2 blobs of composite, these are called root control attachments. And for the central incisors, they've been proven the most effective for angulation. Now, I just want to go back to the mesiodistal translation and the tipping effect, and also the angulation effect. So, for example, we have a molar that is already tipped, and you want to it's already tipped mesially, and you want to mesialize it. With the side effect of tipping, we're going to expect more tipping to happen on that tooth. So before any attempt to mesialize that tooth, we need to angulate the tooth. We need to upright it to its original position. Then we can move on with the mesialization process. But I don't want us to always think of the effects of the tipping side effect as a negative side effect. According to the way you plan your setup, the tipping could play a huge role in your favor. So for example, if we have a molar that is already distally tipped and you're planning mesialization movement on that molar, the tipping side effect that you're going to do is going to actually play in your favor, because it's going to tip the tooth mesially to the direction of movement, which is going to upright the tooth while you are moving it in mesiodistal direction. So it's not about having these side effects as an enemy. It's about realizing how the plastic works imagining the movements happening with the plastic wrapping the teeth, and what side effects should we expect with the movement, and how to play our role, our way around them. Moving on to the next type of movement, which is anterior teeth intrusion. Now, before we go deeper into this type of movement, I want us always to think of intrusion as two separate ways. So we have the absolute intrusion, where we are intruding the tooth or moving it vertically within its same place anterior-posteriorly. So the tooth is in the same place, but we are only moving it vertically into intrusion. While relative intrusion happens when the movement is accompanied by proclination. So whenever I have an incisor like this and I want to apply some proclination, we're tipping the tooth forward, we're gonna get some relative intrusion, because if you look at the incisal edge of the tooth on the right side, after the proclination, after the tooth is more inclined, the incisal edge is in a higher vertical position, giving the appearance of intrusion. And this is what we call the relative intrusion. So this is one of the first synergistic movement that I want us to learn about, since proclination always gives us an amount of relative tooth intrusion. Proclination is a good movement to be combined with intrusion. So whenever we're planning an anterior teeth and we also need proclination, we'll need to know that this happens to our favor. So this is a predictable movement that we can rely on. Similar to proclination of anterior teeth or retraction of anterior teeth, intrusion does not require the use of attachments, but we need retentive attachment for anchorage on posterior teeth. As you can see in this picture here, we're using horizontal rectangular beveled attachment. So another important clinical tip that I can give you is that while we're intruding upper central incisors in particular, extrusive attachment can be placed on adjacent teeth for retention. So this is a little bit tricky. We're doing intrusion, but the attachments we're going to use are extrusive attachments on the adjacent teeth. So you can imagine the aligner trying to put an intrusive force on the incisal edges of the centrals, while it gains its anchorage and retention from applying a force on the gingival surface of these extrusive attachment on the adjacent teeth. Another important note about intrusion that I'd like to share is that intrusion always requires space. So IPR might be needed in some cases. So whenever you get a treatment setup and you're wondering why is there like you requested intrusion and you're wondering why did the dental technician add some interproximal reduction in this place, it's because intrusion, in order for it to predictably happen, we have to provide space. So before we start the treatment, we do some minimal interproximal reduction to provide space between these anterior teeth in order to intrude them predictably. And now I think it is a perfect chance to introduce another auxiliary that is used with clear aligners, which is called bite ramps. So these are hollow projections that are manufactured or fabricated on the palatal surface of upper anterior teeth. So whenever we're aiming for anterior intrusion, especially lower anterior intrusion, these hollow protrusions out of the aligner are going to be hitting the incisal edges of the lower teeth, causing to aid intrusion or facilitate intrusion in both upper and lower anterior teeth. It also acts as a bite razor to disocclude posterior teeth. So whenever we're planning to fix a posterior crossbite and we want some posterior separation, or we're aiming to do some posterior extrusion, these bite ramps could act as a bite razor to disocclude or separate the bite posteriorly. Moving on to posterior teeth intrusion. So this is another thing, or a clinical tip that I want you to think of the side effect, another side effect of the aligner, of the plastic of the aligner. Since this plastic is encapsulating the whole tooth and covering the occlusal surface, we can always imagine that aligners tend to exert a natural intrusive force on posterior teeth due to the natural thickness of the aligner. So this is why a lot of clear aligner cases, you're gonna need a refinement because you've reached beautiful results, but the bite opened a little bit posteriorly. You're just gonna need a quick refinement to close the bite posteriorly, because this effect is very common and in clear aligners, and sometimes it's really hard to avoid it. We just accept it. But luckily, the correction of this side effect is really easy by the end of the treatment. So the amount of intrusion that's predictably done with clear aligners is 0.5 to 1 millimeters. And I can't stress enough that intrusion or posterior intrusion is an advantage that clear aligners have over fixed braces. So whenever you are treating an open bite case, you're always going to gain this effect. This is going to play in your favor, that you can intrude the posterior teeth to separate the bite posteriorly, causing mandibular autorotation and the bite closing anteriorly. This is why, again, open bites, as I mentioned in the beginning, are one of the most predictable malocclusions to be treated with clear aligners, because all of the movements that we are using to treat an open bite are predictable movements. And we learned that by imagining the plastic, by imagining the side effects, and imagining the effects of the force of the clear aligner. So to explain the idea more, so for example, let's imagine that we have an open bite case similar to the one over here, and we intruded, like I'm going to pause the video. Notice posteriorly, the posterior teeth are separated. So we reached a stage in the setup where we applied posterior intrusion, and this posterior intrusion is going to separate the bite posteriorly and allow the mandible to move forward and upward. This forward and upward movements allows the correction of open bites. So if you can check the simulation over here, you're gonna, in cases of open bite, you're gonna get this into the simulation. This is what we called a virtual bite jump. And this is the prediction of the mandibular autorotation that we've been talking about. So when posterior teeth intrusion is planned, I'm sorry. When posterior teeth intrusion is planned, a forward and upward rotation of the mandible takes place. And this is represented by the bite jump or the treatment viewer. So one clinical important tip to whenever you have a virtual bite jump is to always check before the bite jump takes place. So in this video, let's just look at the right before the step that the bite jump takes place. We need to make sure we have enough overjet to allow this forward and upward movement of the mandible. Otherwise, if we haven't planned enough overjet and the technician just planned vertical movement of a bite jump, this is unrealistic. You have to keep an eye out for that. You have to always make sure that you have enough overjet to allow this mandibular autorotation. Another type of movement that we're going to cover is the anterior teeth extrusion. So similar to what we talked about with anterior intrusion and proclination of the teeth, we're going to get relative intrusion. The same goes for extrusion. Once you retract a tooth, so imagine we're retracting this incisor. Once we get it back, you're going to notice that the incisal edge is more of a downward vertical position compared to the initial position. So this is relative extrusion that is always synergistic, and it's predictable movement when it's combined with retraction. So extrusion and retraction are always favorable movements. Whenever you see a treatment setup that the anterior teeth are being retracted and extruded, these are synergistic movements that happen together, and they can be coupled together predictably. While absolute extrusion, and the same goes for absolute intrusion, by the way, it is a more difficult type of movement when we are trying to intrude or extrude the tooth in place. Now, extrusion is a little bit more difficult because, as we said, extrusion depends on pulling. Like if you can imagine, I want to extrude a certain tooth, I'm going to need some pulling factor, which is not present in aligners. We can do around 2 to 2.5 millimeters of extrusion, but this is only achieved with attachment. So this extrusion is considered one of the most difficult movements to achieve with aligners alone, and almost always require attachment to provide a surface to push against when your extrusion is planned. And extrusive attachments always be used during extrusive movement is almost a must. I can't emphasize this enough. Now, for posterior teeth extrusion, as you can imagine, since we said we have a positive side effect of aligners, we always have an intrusive posterior effect, an intrusive effect on posterior teeth. We always, it plays against us when we're trying to extrude posterior teeth. So posterior teeth extrusion, this slide I think is mentioned wrong. It's supposed to say posterior teeth extrusion. I'm sorry about this. So this is not a very predictable movement with aligners due to the natural intrusive force. So in such a scenario, when we're trying to plan posterior teeth extrusion, the box elastics can be useful, and bite ramps, as we mentioned earlier, can be useful to separate the bite posteriorly and use the elastics to kind of extrude the teeth into the final position. So this is all of these auxiliaries that I'm sharing with you. These are all things that you can request during case submission and ask the technician to add. I'm just giving you I'm painting a picture of when do you need to use these auxiliaries in general. But as we go through the lectures, we're going to be giving more practical or like more specific advice on each type of malocclusion or each type of case, what auxiliaries are there to use. I'm just giving you an introduction to get the ideas in general and to get the basic biomechanics of clear aligners. So the final movement we'd like to discuss, I know I'm going a little bit over time. We have 5 minutes left. So the final movement I'd like to discuss is rotation with aligners. Now, for teeth that provide the natural undercuts, as we said before, like for example, the central incisors and the lateral incisors, the rotation is actually more predictable than when we're talking about conical teeth or teeth with rounded roots, similar to canine and premolars. So if you look over here, centrals and the laterals, we can predictably rotate the teeth up to 30 to 50 degrees, while it's less for canines and premolars. That teeth that don't have the undercuts, the rounded teeth, it's going to be harder for the aligner to engage, and you're going to get around 25 to 40 degrees of rotation in clear aligner treatment while you are attempting to rotate canines and premolars. And of course, when the amount of rotation is considerable, like whenever we're talking about a high number of rotation, or the shape of the tooth does not allow the aligner to properly apply the forces, for example, the premolars and the canine, attachments are almost always needed. Similarly to how attachments are almost always needed for extrusion, the same goes for rotation. So you can't go into a treatment with multiple rotation and promise the patient there won't be attachments. Attachments are actually needed for a lot of movements, and they make a difference with the predictability of the treatment setup. So attachments role in rotation, we have different shapes. So this one the one on the left over here is the rotational attachment. And this rotational attachment can be used interchangeably with the vertical attachment. So this is applied on most of the teeth. We can use either one of these two attachments. We're gonna reach more of a rotational support during our movement. But when we go to incisors, specifically lateral incisors, we're going to use the extrusive attachment for rotation. So as you can see over here, I want to rotate this lateral incisor. We're going to use the extrusive attachment, but we're going to place it in an oblique direction to help us apply extrusive movement along with rotation. So for lateral incisors, always keep in mind for rotating lateral incisors, we're going to use the extrusive attachment placed obliquely, which is some clear aligners providers call it the sash attachment or the oblique attachment. And finally, for the central incisors, you can use the root control attachment that we showed you earlier, the two blobs of composite. These can be perfect for the rotation of central incisors. Final feature that I want to share with you before we wrap up this lecture. So remember how this illustration we saw before, that we're trying to apply a simple force with the aligner on a tooth. We're trying to retract it. And as I said, we're going to get a little bit of movement of the root in the opposite direction. So to avoid that, we need to move the force closer to the center of rotation, that is halfway in the root. So to do that, we can request something called torque enhancer. And this is something fabricated with the aligner. You can request it with your treatment setup when you are doing a considerable amount of retraction and you want to maintain torque. For example, if we want to retract a central incisor while maintaining the initial torque, the highest forces are applied on the incisor edge, as we mentioned before. But to maintain the torque and prevent tipping, we will need to apply another point of force towards the cervical area. This is applied by torque enhancer. So whenever you're doing a considerable amount of bodily movement on an anterior tooth, always consider requesting torque enhancers from your technician, and these can make a difference with maintaining the original torque of the tooth. So I just want to go back to one final slide before I wrap off this lecture. If you allow me to go back over here to this slide. Now, if you look at it this way, looking at this list is going to make more sense once you understand the movement. So for example, let's take the open bite. We mentioned that we can get around 2 to 3 millimeters of anterior extrusion of anterior teeth. So in order to close the bite, I want to extrude the anterior teeth, and I can do up to 2 to 3 millimeters of intrusion with aligners. Now, let's say we need the upper limit, we need around 4 millimeters of open bite closing. We can, after doing the 3 millimeters of extrusion on the anteriors, we can also apply posterior intrusion. And we said posterior intrusion is going to help mandibular auto-rotation and a bite jump to close the bite completely. This makes open bites a predictable case because all of the movements required to correct this malocclusion are predictable movements. While if we go to deep bites, we need to intrude anterior teeth. We can get some of that, but we'll also need to extrude posterior teeth. And this is a little bit challenging with aligners, especially because of the natural intrusive force that aligners apply on posterior teeth. So I hope the idea is clear in general. I hope by this point you can just look at cases and imagine the movements that are needed and have an idea whether this is an ideal or a predictable movement to predictable treatment with aligners, or is this a more challenging treatment that I need to keep later on. Of course, with the upcoming lectures that we're going to provide with my colleague, Dr. Farah Majdalawi, we're going to be able to provide you with more specific tips for malocclusions. So I imagine by this point, you have a general idea, but you're not going to be able to select the right auxiliary or the right movement setup for a certain malocclusion. But with time and with the upcoming lectures, you'll be able to identify the certain amount of force, the certain amount of auxiliaries that you need to treat a case predictably. And that was everything for me.